Welcome to the NWAETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to our speaker for the talk today.
I really appreciate this opportunity to present. Usually I'm on the receiving end of this program, and it's rare for me to be able to be on the sharing end, so thanks up front just for allowing me to do this. Today, our outline will include 3 topics. We'll look at the UNAIDS 90-90-90 targets and how that is impacting potentially new World Health Organization treatment guidelines. This is probably the hottest topic at the conference, and it impacted so many things that were discussed. And in looking back 20 years ago, the International AIDS Conference was in Vancouver, and the hot topic at that meeting was the 3-drug combination therapy and how that led into protease inhibitors, which actually became a game changer for HIV in the last 20 years. And now the question in my mind at the meeting was, how is the START study results, how are the HPN 052 results, and going to impact us going 20 years forward? And hopefully all of us will be practicing in 20 years and be able to see how that works out. So the next point in the program today is actually looking at HPN 052 and those results, and HPN 067, which is kind of a unique study looking at the acceptability and adaptability of folks to use daily versus non-daily PrEP. All right, and this is actually a slide that looks at the UNAIDS 90-90-90 targets, which, as you can see on the slide, it means that by 2020, 90% of all the people who are living with HIV will be diagnosed, and of those diagnosed, 90% will be treated, and of those treated, 90% will be suppressed. Those are amazingly ambitious goals. Look at the numbers involved. The gap in that first target of 53% of total people who are estimated to be infected with HIV ends up being 13.4 million people. And the second and the third breakpoints also are very significant numbers of people. So the sessions at the conference were looking at those gaps and how to best address them. Certainly that first gap is the greatest challenge. But several things were discussed. Improvements in testing services, for instance, were discussed. The new WHO recommendations involving layperson testing and also a greater reliance on self-testing. Feedback, combination prevention programs involving biomedical, behavioral, and structural community interventions. But the most significant thing that came to my mind was the new point-of-care testing technologies. Imagine a world where you can do point-of-care testing for viral loads and CD4 cell counts, and imagine the impact that that might have on early infant diagnosis and for routine screening and for treatment monitoring. Having worked in a rural area in Alaska, I can only imagine how that might impact our ability to provide care for HIV patients. This particular slide looks at how treatment is prioritized around the world based on CD4 cell counts. And notice just the blue regions of the world, and those are the regions which have policies to treat HIV irrespective of CD4 cell counts. And what will be interesting as we go forward now as a result of the START trial conclusion is to see how the policies in those other countries change to hopefully begin treating people earlier. As you know, the START study demonstrated a 57% risk reduction for serious AIDS and non-AIDS related events when treatment is started earlier versus later. This particular slide is taken from a presentation by Rachel Bagley with the World Health Organization discussing new consolidated guidelines on HIV testing. And the point of the slide was to illustrate who bears the bulk of the disease, males versus females. But I think it also illustrates the magnitude of the epidemic, because it notes that 2 million adults tested positive during 2014 in 65 low and middle income countries. And it makes a disclaimer that, some of those were known positives and retesters, but when you think about the sheer number of 2 million people, that translates into roughly 6,000 cases per day. And if you try to understand that in terms of the incidence of HIV in the United States, that means our 42 to 45,000 rate of incidence will be achieved in the next 7 to 10 days. Now that tells you something about the size of the epidemic worldwide. This particular slide looks at the proposed guidelines that will probably be coming out later this year. And the recommendations will be to treat all regardless of CD4 cell count, to continue to make the sickest people who have CD4s less than 350 a priority, and to make option B plus the new standard for pregnant females, which is, of course, it addresses vertical transmission, mother to child, and will be offering treatment to women for their life rather than just during the course of their pregnancy. And then the next is to make the integrase inhibitors like dolutegravir part of first and second line therapy. Also to include PrEP in select populations. And that concludes our discussion of the 90-90-90, but the next slide now will take us into HPN 052, which I think everybody realizes was the landmark prevention study, which has tremendous implications for PrEP, and was, of course, a large phase 3 randomized trial involving almost 800 serodiscordant couples living around the world in 13 locations, and the primary objective was to see how treatment of the HIV-positive partner affects the risk for sexual transmissions for HIV. And as you remember, 97% of the couples in the study were heterosexual, and the median age was around 33, and the entry-level CD4 cell counts were around 350 to 500, and there was a balanced number of men and women involved in the study. After the May of 2011, or in May of 2011, the Data Safety Monitoring Board for the study called for a release of the interim results because there was documented a 96% reduction in risk for sexual transmission, as we all remember. And at that point in time, all the participants in the delayed arm were also enrolled in treatment or were eligible for treatment, not that they all began right away. And then the study was continued until May of this year to determine whether the preventive effects of treatment would be durable. This chart was actually presented by the principal investigator, Dr. Myron Cohen, and I got to shake his hand, fortunately, at the meeting. The chart summarizes the intention to treat data for the overall risk reduction for the index partner, and that amounted to 93%, a 93% risk reduction. And you remember the interim results showed like a 96% reduction, and a question that came to my mind, well, why the difference? But if you look there in the middle of the chart that's bolded for the period May 2011 to 2015, you'll see that when all the couples were able to be enrolled in care, the preventive effects of treatment began to impact the delayed arm too. And this actually blunted the relative risk reduction for early versus delayed treatment by lowering the transmission risks for both arms of the study. And so the new significant outcome became linked partner infections while receiving suppressive ARV therapy. And so if we look at the next slide, it actually shows those linked partner infections. There were only 8, and 4 of those occurred before virologic suppression, and 4 occurred after virologic failure. And we were told that there would be more sub-analyses coming, which is very encouraging. So the conclusions of HPTN 052 were that the preventive effects of ARV treatment is durable, that no link to HIV transmissions occurred when the HIV-positive partner was on suppressive therapy, and that the proof now is truly definitive that suppressive treatment prevents the sexual transmission of HIV. And that's actually a monumental thing to have finalized. So now we'll proceed to the next slide and discuss HPN 067. For the benefit of those who may not be familiar with this particular study, it's a phase 2 randomized open-label study to evaluate the feasibility and the acceptability of daily versus non-daily PrEP. It was inspired in part by the French IPERGAY study, which you know is for the non-daily PrEP study, which showed that dosing before and after sex effectively prevents HIV infections when approximately 4 tablets of Truvada are taken weekly. So that's the background. HPN 067 was designed to see whether people from different demographic regions who potentially have sex less frequently would be likely to take PrEP as prescribed, and they did that primarily by measuring adherence and coverage of sex events. However, they did measure some other things. The study was not designed to assess efficacy, and that's important to remember. It included over 500 participants from 3 sites. There were men who have sex with men and transgender women from Harlem, New York, and Bangkok, Thailand. And there were women who have sex with men from Cape Town, South Africa. And this is really important. All participants were informed that only the daily regimen had been proven effective to prevent HIV infection. This summarizes the study design. It actually included a 6-week direct observed therapy period, near the end of which participants were randomly assigned to one of 3 PrEP dosing regimens for 24 weeks of self-administered dosing. And as you can see, there was a daily arm with once daily dosing. There was a time-driven arm, meaning twice weekly dosing with a post-intercourse dose. And then there was also an event-driven arm, meaning a dose before and after intercourse. And the study required that no more than 2 tablets per day or 7 tablets per week would be allowed. Okay, the outcomes, primary outcomes of the study included the coverage of sex events, the number of tablets, which meant required versus taken, and the self-reported side effects. The secondary ones, as you can see, included adherence, safety, acceptability, and HIV infections. The most significant findings, though, involved differences in coverage of sex events and adherence. Coverage of sex events was defined the same for all 3 arms of the study, and only vaginal and anal sex acts were considered sexual events. And a sex event was covered if, as you can see on the slide, there was at least 1 pill taken 96 hours before the event and 1 pill taken in 24 hours after the event. We'll take a look at the outcomes. When you consider coverage of the sexual event, complete coverage varies from site to site, of course, but all sites had the highest percent coverage of events in the daily arm of the study. The Bangkok site had the highest percent coverage for all 3 arms of the study. And remember, that was men who have sex with men in Bangkok primarily. The doses missed most often were the after-sex doses, and that usually applied to the time-driven and the event-driven arms of the study, and that led to incomplete adherence, or coverage, I should say, sorry. The next slide has to do with adherence. If we look at the adherence outcomes, adherence was defined as the total tablets taken over the total tablets required for each arm of the study. And adherence, again, was best for the daily arm of all 3 study sites. It was lowest, as you can see, for the Harlem site, and highest for the Bangkok site across all arms of the study. And adherence was highest for Cape Town, only in the daily arm, but moderate in the time-driven arm. We can look more at that later, but to go to the next slide and we'll talk about another outcome that they looked at, which is they measured tenofovir diphosphate in peripheral blood mononuclear cells, PBMCs, and they did that at week 10 and week 30 in all participants who reported having sex during the previous 7 days. And the results actually were in line with the data of adherence and coverage of sex events. Over 85% also of the Bangkok participants had detectable drug across all 3 treatment arms, and they were the most compliant, whereas the Harlem and the Cape Town sites were more likely to have detectable drug only in the daily arm. The conclusions of this particular study was that the daily PrEP does result in higher coverage of sex events and higher drug concentrations and higher adherence. Non-daily dosing, however, may be a viable option for some MSM who are motivated to anticipate their sex events. And daily dosing, however, fosters habit formation, provides the most forgiveness for missed doses, and requires no planning for sex. And now the last slide is a great chart that I picked up from one of the presentations excuse me, of the overall evidence for PrEP as of July 2015. As you can see toward the top, there are various studies involving men who have sex with men or possibly serodiscordant couples where there's very good evidence for PrEP. And as you go down the list, maybe less convincing evidence for the use of PrEP in women. And that concludes my talk.